Jai Hind to all of you. Can you hear my voice? Okay, give it 2 more minutes. I'm just there's some issue with the camera. And, yeah, Jai Hind. There was some issue with the camera. We have just sorted it out. Give me 1 minute. Okay, so I am ready to go. Okay, fine. So we'll start with today's class, which is on dysphagia. We are seeing around 48 students. Wish all of you a very happy festive time and a happy Diwali. I'm sure all of you would have enjoyed a good time. Uh, Thanks to all of you. There was some, I believe, I always thought that you all will be joining in department in Pune post Diwali, but probably now we will be coming in first week of December. Anyway, so we have our last lecture today, which is on dysphagia. Uh, okay, so I'm sure all of you would have got the presentation on this topic. So we begin with today's topic. Uh, so swallowing is something which all of us take so much for granted, just as speaking, just as breathing. Similarly, swallowing is something which we all of us take so much for granted. We need to understand that swallowing is a specific mechanism, and there are many people who have difficulty in swallowing because of various reasons. And so begin, I always say that to be able to eat a meal that has been specially and lovingly prepared is one of the life's most satisfying pleasure. And so let us understand dysphagia today. We will, in this topic, we'll understand mainly about the anatomy of esophagus. That is, what is the basics of esophagus that you should be aware of in ENT. Physiology of deglutition. To understand in throat, till now we have understood physiology of speech. Now, this is we need to understand about physiology of deglutition. Then, if a patient comes to us and says, I am having difficulty in swallowing, then how to approach that patient? That is, we need to understand various causes for dysphagia and how to approach a patient with dysphagia. So, again, going to the anatomy of esophagus. Going to the anatomy of esophagus. Before that, can someone tell me two or three points about physiology of phonation? One or two ways in which phonation took place. What was the mechanism in which phonation took place? There were three principles which we understood, which told us about phonation. What were those three principles? Anybody? Anyone? Principles of phonation or phonation physiology, because now we are discussing about deglutition, so we should not forget about phonation also. Abhinav says aerodynamic theory. You need to add one more word to it. That is, one more word is to be added along with that, and that word is myoelastic aerodynamic theory. It is myoelastic aerodynamic theory, right? Any other theory which any of you are aware? Myoelastic, right? So Bhaivavi says myoelastic to be added. Yes. Shruti Singh says body cover theory. Correct. Second is body cover theory, and one more point, one more thing, which is quite important. So body cover theory, myoelastic aerodynamic theory. Kashmir speaks also says myoelastic theory. Yasmiki says yes, mucosal wave. So right, mucosal Muskan also says mucosal wave. So yes, mucosal wave theory. Right, Shaurya. Mucosal wave theory, myoelastic aerodynamic theory, and body cover theory where the mechanisms for physiology of phonation. Right, and I asked. Now coming back to anatomy of esophagus. So anatomy of esophagus. Esophagus starts. Esophagus starts where the hypopharynx is ending, or where the hypopharynx ends. Where the hypopharynx ends, the esophagus starts. I am repeating, where the hypopharynx ends, the esophagus starts. What were the parts of hypopharynx? Quickly, three P's in hypopharynx. Three P's of hypopharynx. Come on. Posterior phalangeal wall, Aditi says right, Tanaya says piriform fossa, correct. And one more P is Muskan, posterior phalangeal wall, piriform fossa, एक और चीज चाहिए साम्या, piriform fossa, repetition हो रहा है, one more P. Kashmir says post-cricoid area, right Shreya, post-cricoid area. So post-cricoid area, posterior phalangeal wall and the piriform fossa, they form the hypopharynx, right? Now all of you are getting the answer, which is the next speed which is causing it, the delay. Right. So what is happening is the food and so the piriform fossa is a pyramid shaped fossa which directs it's like a funnel which directs the food to the upper end of the esophagus. The upper end of the esophagus. Now, esophagus is something which does not have any bone. It is a fibromuscular tube. So, when you are writing a short note on esophagus anatomy, right, it's the fibromuscular tube. The length of esophagus is 25 centimeter. In adult, the length of esophagus is 25 centimeter, 25 centimeter long. Uh, Definitely, the length varies with the age. At birth, it is generally around 8 to 10 centimeters. Again, MCQ question: what is the length of esophagus at birth? It is generally around 8 to 10 centimeters, and gradually it progresses to the adult size of almost double. That is more than double. That is 25 centimeter size. The extent of esophagus extends from C6 to T11. C6 to T11 is the extent of esophagus, and it has got two lateral curvature on the left side. So two lateral curvature on the left side. So esophagus is a fibromuscular tube, length 25 centimeters, extending from C6 to T11, and two left side lateral curvatures. All of these are MCQ questions. That is the length, the size at birth, and the extent and the curvatures. Two left side curvature. Uh, Besides, very important, very commonly asked during your table viva when you are given a esophagoscope, or very common question in the in NEET exams about the constrictions. Now there is a doubt regarding, or there are two answers regarding this. Some books mention there are four constrictions. The Dhingra mentioned there are three constrictions. Remember, some books mention four constrictions. So if somebody says there are four constrictions, he is not totally wrong. Generally, we always see there are three constrictions. The first constriction from start to end is 25 centimeter. From start, at the first 15 centimeters, we get the first constriction. So we have fibromuscular tube. As we are going inside the tube, when we reach 15 centimeter, we get the first constriction. Constriction in partial narrowing. Then further 10 centimeter down, that is 25 centimeter, we get the second constriction. And then further 15 centimeter. So 15 centimeter, then further 10, 25 centimeter, and then further 15, 40 centimeter. There are three main constrictions present. The first constriction is the cricopharynx area. The first constriction is the cricopharyngeal area. The second constriction is present where the arch of aorta, or the left main bronchus, and at the 40 centimeter is where the esophagus pierces the diaphragm. Now, question. We discussed that esophagus length is 25 centimeter. We discussed that esophagus length is 25 centimeter. Then how is this 40 centimeter length? How are we seeing a constriction at 40 centimeter? We discussed that esophagus length is 25 centimeter. Then why are we getting a constriction at 40 centimeter? Yes says it is from incisors. Yes, it is from incisors. Adi also says same. Apurva, right. So all of you have this concept that when Yuvraj from incisors, yes. So when we are talking of constrictions, it is from the incisor teeth. But why from the incisor teeth? Why from the incisor teeth? Why not from the start of esophagus? Why can't we say 0, 10, and 15? Why do we want from the incisor teeth? Why can't we say now first is 0, then 10, and then 15? Adi says easy landmark. Landmark for what? Why can't we say upper end of esophagus, then 10, that is 0, 10, and 15? Esophagoscopy becomes easier, Anaya says. Right, right. So, visible landmark, Yuvraj says. Right, Anaya, I'll go with Anaya. What she is saying is esophagoscopy becomes easier. More than that, RT insertion, Shaurya says. Muskan says esophagoscopy. Okay, yes. So, the constrictions are important because when, as a surgeon, we are doing a esophagoscopy, when, as a surgeon, we are doing a esophagoscopy, when I put the esophagoscope I have to see the esophagoscope. It goes from the mouth and then reaches the esophagus. So when I'm inside the mouth, I should be aware how deep I have gone. So upper incisor forms the most starting point from where I can get, and as I go down, the moment I reach the zero, that is the upper level of the esophagus, that is 15 centimeters. So from incisor at 15 centimeter, I get the entry point of the esophagus, which is the first constriction, which is the level of the cricopharynx. It is also the narrowest part of the esophagus. It is also the narrowest part of the esophagus. Cricopharynx is also the narrowest part of the esophagus, or for that matter, it is the narrowest part of the entire aerodigestive tract, and so it is a common site for foreign body. So first constriction at 15 centimeter from the incisor teeth, second constriction at 25 centimeter, which is at the crossing of the aortic arch or the left main truncus, and last constriction is where the esophagus enters the diaphragm, that is where the pierces the diaphragm. Now, some books which have mentioned four constrictions. So, when you are attempting MCQ in NEET exam or any exam, see to it, read the questions properly. Books which have mentioned four constrictions, they say that first constriction is at 15 centimeter, second constriction is 23 centimeter, third constriction 27 centimeter, and fourth constriction at 40. Actually, we get four constrictions, but because the second and third are very very close, so they are taken as one constriction. First is cricopharynx, second at 23 centimeter is the arch of aorta, third 27 centimeter is the left main bronchus, and last where the esophagus enters or pierces the diaphragm. Coming to next slide now, so we have understood about the anatomy of the esophagus. We have understood about the anatomy of the esophagus. What is the extent of the pharynx, by the way? We understood that the esophagus extends from C6 to T11. What is the extent of pharynx? Pharynx, first lecture, if you remember. Anyone, what is the extent of pharynx? Bolo, bolo. Gursimar Kaur says C3 to C6, Muskan says C6 to C6. You are right. We just mentioned that where the pharynx and esophagus start. So from C6, so the lower level of pharynx is C6, and from the C6 esophagus starts, and C6 से ऊपर, 3 vertebrae ऊपर, so C3 to C6. You are right. C3 to C6 is the extent of pharynx. So C3 to C6 pharynx, C6 to T11 is the esophagus. Now coming to next slide, that is the physiology of the swallowing. Physiology of swallowing. Remember, swallowing happens in three phases. I am sure all of you would have understood or understood in extreme detail about swallowing in your physiology classes, but we need to just revise it and put it very, very in applied aspects how much is important for us. So when you are writing the physiology of phonation, first you write definition, that is swallowing is basically the mechanism by which the food that we are eating is reaching the stomach. The process by which, to define it, the process by which the bolus of food is transferred from the oral cavity to the stomach. The process by which the bolus of food is transferred from the oral cavity up to the stomach. That is swallowing. It happens in three phases. That is in the oral cavity, in the pharynx, and then third part in the esophagus. So you write definition, then you write it happens in three parts, that is the oral cavity, the pharynx, and then in the esophagus. Stage 1 and partially stage 2. Stage 1 and partially stage 2. Or forget, stage 1 is a voluntary phase, and stage 2 and stage 3 are involuntary phase. Stage 1, that is the oral cavity phase, is a voluntary phase. So the moment the food is in our mouth and we are using saliva, tongue, teeth to grind and to form the bolus, it is voluntary. It is in our control whether to take it out or take it inside. But the moment food reaches the pharynx or the esophagus, more or less it becomes involuntary, and then the food automatically reaches the esophagus. So stage 1 is the stage is the oral cavity phase, where tongue is the most important organ in the mouth. Understand, tongue is the most important organ in the mouth, because even if we don't have teeth, it is possible to form the bolus with the tongue, and patient can swallow. But somebody not having tongue, it becomes very, very difficult for him to swallow. Though he has teeth, he has everything in the palate, but if he does not have tongue, it becomes extremely difficult to swallow. That is why in cases where there is total glossectomy surgery is done, if the patient's condition becomes extremely morbid, he is not able to swallow though he has all the teeth. So remember, tongue is the most important part. It mainly helps in formation of bolus, and it forms the bolus and pushes the tongue in the oropharynx. The tongue and pushes the bolus of the food in the oropharynx. So tongue helps in formation of bolus and pushes this bolus of food in the oropharynx. Now, second phase, pharyngeal phase. It is extremely interesting to understand how, now when the food reaches oropharynx, there are three passages. One is above in the nasopharynx, second is one in the hypopharynx, and third is in the larynx. There are three passages where things can go. So it is extremely coordinated manner in which the soft palate closes. So the food does not reach the nasopharynx. The soft palate closes. So food does not reach the nasopharynx. Epiglottis closes. Larynx closes. So food does not reach the larynx. And thus the food enters only into the piriform fossa. The piriform fossa, like a funnel, directs this food bolus into the upper end of the esophagus, and from there the esophageal phase starts. In the pharyngeal phase, the most important part of the oropharynx is the food should not enter the airway. It should not go in the nose, and so the soft palate is closing. It should not go into the larynx, so the epiglottis closes and the larynx also closes. Thus, when we are swallowing, when we are swallowing, during that moment, we have to stop breathing. We cannot breathe and swallow together. Is there some condition where we can breathe and swallow together? Or is there certain way, is there certain physiological condition where human can breathe and swallow together? Yes, says infants. Imani, Muskan, all of you are saying infants. क्यों ऐसा होता है? Rachita also says infants. But why? Why is that infants can swallow and breathe, but as adults we cannot swallow and breathe together? Why is that infants? What is the difference? Kamya says higher epiglottis. I would add to it, instead of higher epiglottis, the entire larynx is high, right, Imani? High placed larynx. Larynx is at high level. Yes, larynx is at very high level. So the air from the nose can directly go into larynx, and the food goes into the larynx. So the child can suck the milk at the same time breathe also. So right, all of you have got this. High level of larynx is the reason why the child, and as the child grows, the larynx position keep going down, and then this coordinated effort is required for the food to not go into larynx. However, sometimes all of us, when we are eating fast or when our focus is somewhere else and still we are eating, sometimes food particles or water can go in larynx, and that time we get cough. That is called as swallow cough, or that is called as aspiration. Occasional aspiration while eating, all of us have. Very, very occasional aspiration while eating, all of us can have. But in certain malignancies, aspiration is a very important symptom. In certain malignancies, aspiration is one very important symptom. Anyone? Which malignancy? Aspiration is an important symptom. Obviously, it is not glottis because glottis has got CA larynx is a very vague term. Good word. CA larynx is a vague term because it is, when we say CA larynx, it becomes CA glottis, and glottis is mainly change of voice. Which part of larynx? Glottis and supraglottis, sorry, again being too vague. It is just like CA larynx. Supraglottic CA. Anaya says supraglottic CA. Right, right. Good, Simon, right. So supraglottic CA is one reason, is one condition where because of the growth in supraglottis, the closure mechanism is not very good. At the same time, the nerve endings are also not very functional, and so food can enter the supraglottic area, and patient may have aspiration. Right. So we have understood the first stage, that is the oral cavity stage, where the teeth grind, the tongue forms the bolus and pushes in oropharynx. In the pharyngeal phase, uh, food does not reach the airway because of this reason. Now comes the third phase, that is the esophageal phase. Very, very easy. Normally, the upper esophageal sphincter is always closed. The esophagus is a fibromuscular tube which is always closed. And so while we are breathing, air does not go into the esophagus because it is normally closed. Except in certain cases when we are breathing very fast with mouth open, some amount of air can go in the esophagus and that is belched out. But most of the time when we are breathing, the air does not go in the esophagus, it is going mainly in the larynx. However, when the food reaches the upper end of the esophagus, that is the upper esophageal sphincter, the moment there is a sensation there in the fibromuscular part, the esophagus opens up. And the esophagus opens up, the lower part is narrow, and by a peristaltic movement, that is upper part dilating, lower part narrowing, again dilating, narrowing, dilating, narrowing. By this movement, that is the peristaltic movement, the food reaches the lower esophageal sphincter, and that sphincter opens and food enters the stomach. So the esophageal phase, you write that food reaches upper esophageal sphincter. With the stimulus, it opens. By peristaltic movement, it comes down, and from the lower esophageal sphincter, it enters the esophagus. Those patients who have those patients who have weakness of the lower esophageal sphincter, those patients who have weakness of the lower esophageal sphincter will have reflux esophagitis. That is, the acidic food may enter from the stomach. Normally, these are one-way sphincters. The food does not go reverse, but in those conditions where the lower end of esophageal sphincter is sometimes weak, the food or the acid can gastric content can reach the esophagus and patient might have reflux esophagitis, in which what disease or what condition may happen if the upper esophageal sphincter is weak. Which condition or which disease is known to happen when the upper esophageal condition is weak? Basically, GERD is when the lower esophageal sphincter is weak. It is gastroesophageal reflux disease that happens when the lower esophageal sphincter is weak. Or if you are saying that, Anaya, Harshita, it is the GERD is mainly heartburn sensation, pharyngoesophageal reflux, Adi says. Pharyngoesophageal reflux, right? However, the more common, I'll give you the more common term. You can leave it, no, really. Yeah, the more common term is LPRD. The more common term is LPRD. Anyone, what is LPRD? We had discussed this when we discussed about CA larynx. LPRD, anyone? Anyone LPRD? क्या होता है? Pharyngo reflux. P is pharyngo. R is reflux. R is already told. What is LND? So it is laryngopharyngeal reflux disease, right, Harshita? Good, Kumar. right. So it is laryngopharyngeal reflux disease in which it may not be the excess of gastric juice production. It is mainly the reflux from the lower sphincter and the upper sphincter, which comes in larynx, and patient starts having laryngopharyngeal reflux disease, which is mainly a disease of recent times, more seen in sedentary in those patients or those people who have got sedentary lifestyle, who have got eating too much of fast food, having habits of tobacco and smoking. They start having laryngoesophageal reflux disease, that is something stuck in the throat. Many of you would have heard your friends saying reflux disease, which mainly connection issue, which mainly happens because of upper esophageal sphincter weakness. Okay. So we have discussed about the anatomy of esophagus. We have discussed about the deglutition physiology. Now, last part of today's class is a patient has come in front of you. He's sitting and he says that, doctor, I have got difficulty in swallowing. So, how will you approach a patient with dysphagia? Or more so, if one of your friend or relative or somebody neighbor comes and says कि मुझे खाना खाने में तकलीफ हो रही है, he says I'm having difficulty in swallowing, how will you approach? Whenever we approach any condition, say it will be fever, say it will be change in voice, or it will be stridor, whenever we approach any condition, we should be aware about the common causes. Only then we can approach. So, the moment someone says that I have got dysphagia, in your mind you should start thinking of all the common causes for dysphagia. Now we understand that for dysphagia to happen, there might be a problem in the oral cavity, in the oropharynx, or in the pharynx, or in the dental caries. You might have a lubric angina. You might have, say, small aphthous ulcers. You might have tonsillitis. You might. So all these conditions are all these conditions are painful conditions where patient might have difficulty. May he say that he is having difficulty in swallowing. When there is painful swallowing, what do we call this? What is it called as? Painful swallowing? Painful swallowing is called as Shaurya, Himani, Dusima, right? Odynophagia. So this odynophagia is, so all these are painful conditions where patient with odynophagia. Second, right away, all of you are right. So second, that food is reaching the esophagus. But esophagus, now for the food to go in the esophagus, there should be a coordinated peristaltic movement which should take place. There should be a coordinated peristaltic movement. That is, the upper part should constrict, lower part dilates. Then constriction, dilation. This is a coordinated effort which takes place. However, there are conditions where there is hypermotility. So some part is, so the esophagus is contracting without any coordination very fast. Hypermobility. So diffuse esophageal spasm. Diffuse esophageal spasm is one important condition, or glycopharyngeal spasms. These are where the esophagus starts having recurrent multiple spasms, and the esophagus becomes hypermotile. So anybody, what is the X-ray feature seen in diffuse esophageal spasm? X-ray, very common NEET question, very common MCQ question. What is the X-ray feature seen in diffuse esophageal spasm? Good Simon, corkscrew esophagus, right? Corkscrew esophagus. It's like a how we see the wirings in the lower part, the threads of the screw. Similarly, we see the and we do an X-ray, we get the threads. And what is this X-ray called? Which X-ray are we doing? Is it X-ray neck? What X-ray is this? Where we get a corkscrew esophagus? Which X-ray is this? To see esophagus. Shaurya says barium swallow. Yes, so it is barium swallow where which will show us corkscrew esophagus, also called as nutcracker esophagus. So one is painful condition. Yes, Apu, right. Apu, Harshita, right. So hypermotility condition, or the esophagus might be contracting very slowly, especially in old age. In old age, when the esophagus contraction takes place slowly and the non-coordinated manner, it is called as press by esophagus. Just as reduced hearing because of age is called as press by effusis, Reduced vision because of age is called as presbyopia. Reduced or difficult swallowing because of age is called as presbyesophagus. Besides neural conditions like eclasia, cardia, myasthenia gravis, the motility will not be good. And there can be conditions where the esophagus itself has become, or the complete area has become narrow. There is a malignancy which is completely constricting the area. So malignancy might be there, or patient might be having a history of the corrosive poisoning. So complete corrosion and complete narrowing has taken place. There might be a stricture, there might be compression from a lymph node from outside. It can be a mediastinal lymph node or a malignancy in the neck which is compressing from outside. So it can be compression from outside by a malignancy or lymph node, or it can be narrowing of the lumen from inside by a growth in esophagus, or by esophagitis, or by strictures. So any of these conditions of this Plummer-Vinson syndrome is one important feature which is also can lead to narrowing or dysphagia. Plummer-Vinson syndrome is also called as, there is another name for this. What is the other name? Plummer-Vinson syndrome is also called as, one more name for Plummer-Vinson syndrome. Bro, क्या नाम है और? Also called as, even Patterson-Brown-Kelly, yes, Shruti is right. It's Patterson-Kelly syndrome. So Plummer-Wilson syndrome is also called as Patterson-Kelly syndrome. Both share, right? It means the same thing. So one is in US, one is in UK, but then you have to understand that Patterson-Kelly syndrome is same as Plummer-Wilson syndrome, right? These are the causes. The moment somebody tells you कि मुझे खाना खाने में तकलीफ हो रही है, I'm having difficulty in swallowing, I'm having painful swallowing, in your mind it is strike. Is it something to do with oral cavity? Is it something in the pharynx, or it is something in the esophagus? Is it a painful condition? Is it a hypermotility, hypomotility, or narrowing of the esophagus? Okay, so this is the thought process which should start in your mind. So he says sideroblastic dysphagia. You can say that. So, so this is the thought process that should go in your mind the moment somebody says dysphagia. So when you are writing a long question on approach to dysphagia, you write what is dysphagia, that is difficulty in swallowing, common causes for dysphagia, and now when the patient comes, the history that you take will be whether there is difficulty in solids or liquid, because when there is a actual narrowing because of malignancy, the patient will say that I am able to swallow liquids, but I am not able to swallow solids. And gradually he will say that after few days, even liquids is becoming difficult to swallow. That is typical history of a progressive narrowing of the lumen. It can be malignancy. But however, when the patient says that I am able to swallow liquids, but I am not able to swallow solids, think in terms of neurological condition, whereby solids may pass down with the gravity, but liquids doesn't pass, they spill, and the patient starts having aspiration. Then we need to ask about history of any acid reflux present or not. We need to, sometimes there can be functional dysphagia, that is patient may not have any cause. He might just be a bit of depressed, anxious, and he will feel he is not able to swallow. So there is a functional cause to that, but that should be labeled only when we have ruled out all other causes. Then beside this, we need to ask for any regurgitation, retrosternal pain. We need to ask for any hematemesis, any blood in the sputum. Also, there might be associated supraglottic malignancy, so any aspiration history you need to ask, hoarseness, cough, or any weight loss. All these needs to be asked. History of anemia needs to be ruled out. So these are the questions that we ask to a patient during the history. Then we examine. The examination begins from general examination, whereby we look for the temperature, pulse, blood pressure. We look for anemia present or not. We palpate the liver because patient might have a portal hypertension. We look for any condition of the skin, that is patient might have a thyroid condition. There might be skin changes during anemia or scleroderma. We need to look for, because if patient is not been eating for long, there will be signs of malnutrition. So all these things need to be looked for, and then we go to ENT examination, where we look for local cause, teeth, alveolus, floor of mouth, tongue, hard palate, soft palate. Himanshu is saying audio not clear. Okay, I'll try to speak a little bit louder. Let me know if this is clear. Let me know if this is clear, Himanshu. मेरी आवाज पहुंच रही है? Okay, so just some of you say yes if it is clear, no if it is not clear. Better. Okay, thanks. Uh, okay, so oral cavity. So then we examine the oral cavity where we look for any local causes. Once we have checked the oral cavity, oropharynx, we use a ideal mirror, that is indirect laryngoscopy mirror, to look for the rest of the oropharynx, vocal cord movement, and any pooling of saliva in the pyriform fossa. Remember, if patient have got a upper esophageal growth, if patient, I repeat, if the patient have got a upper esophageal growth, food will not pass and it will start collecting in the pyriform fossa. And when we do a ideal evaluation and if we see liquid or saliva in the pyriform, it is called as Jackson's sign, which is a sign of supra or upper esophageal malignancy. So we see oral cavity, we look for neck for any neck nodes, we do a ideal evaluation to look for the oropharynx and the larynx. Then comes radiology, that is one of some of you rightly said that we go for barium swallow to look for any malignancy, any ecclesia cardia, any corkscrew esophagus. We also look for neck lateral view to rule out any infectious conditions, especially retropharyngeal abscess. In which condition, one question, in which condition when we do a X-ray neck lateral view, we get a thumb sign. When do we get a thumb sign? In which condition X-ray neck lateral view we get a thumb sign? That is that we see a thumb sign. Sorry, a point for anybody? No. Thumb sign is seen in case of acute epiglottitis. And when do we get to see a turban epiglottis? When do we get to see a turban epiglottis? Anyone? And which is a clinical finding, not on the X-ray. Who says group? No. Turban epiglottis? No, no, no. Group will come to that. What is this X-ray seen? Turban epiglottis, Tashu, TB larynx. Yes. Tuberculosis, Adis is right, Tashu right. It is tuberculosis of larynx that we see at turban epiglottis. Remember, turban epiglottis is a clinical finding. We actually see it. However, thumb sign is seen in acute epiglottitis. Uh, who Hariharan said that croup. What is the X-ray featuring croup? What is the X-ray featuring croup? What is the X-ray feature in croup? Tashu, steeple sign, yes, the airway becomes extremely thin, like a steeple. So it is a steeple sign that is seen. Archita, right? Coming back to dysphagia, like back to dysphagia, we do our X-ray, barium swallow, we do X-ray neck nodes, we also do X-ray chest, and if we have a suspected malignancy, we have to investigation of the neck. Very disturbed. Yes. Now, other investigation that we have is once we have done an X-ray barium swallow and we have a suspicion, we have to do a esophagoscopy. Now we have either rigid esophagoscopy or a flexible esophagoscopy. We have either rigid or a flexible where we put a esophagoscope inside and try to look actually for any finding. We can either find a growth, we can find esophagitis. If you have that picture, we see there is a diverticulum, there can be fungus. If there is a growth, we can take a biopsy from that. So investigation wise, we have barium swallow, that is X-rays. We have got esophagoscopy. Then there is one investigation is manometry. Nowadays it is coming up in it's a recent investigation done in very few centers, but you should be aware of this that there is a way in which we can measure the pressure of the upper esophageal sphincter. Because the conditions of reflux esophagitis and LPRD are increasing, we need to understand that because of the upper esophageal sphincter spasm is present. So to check for the pressure of this upper and the lower esophageal sphincter, esophageal manometry is an important investigation. Only name is important for you as of now, but understand esophageal manometry is an important investigation. And lastly, we have pH metry. where we check for the how much acid is trickling throughout the day. So manometry and pH metry are important for reflux kind of conditions. Bariums follow, bariums follow, and CT scan and endoscopy will give us idea about the local conditions. Siddharth, I'll get back to you. So, thus we are discussing an approach to a patient of dysphagia. We need to take proper history. We need to do proper evaluation, and once we reach to a diagnosis, we can treat that specific condition. So, to conclude, we have understood about the anatomy of the esophagus, physiology of deglutition, and approach to dysphagia. That was all that I had for today's class. You can go through your textbook. With this, we come to the end of all the lectures of throat. Siddharth, please keep uploading videos of ENT. Sure, I'll try to do as much as I can. Also, go through the older videos. You'll get most of the things there. Students, any doubt in about dysphagia? Please ask right now, or you can even put in the comment section. Great. So I don't see anybody asking any doubts. Still, if you have doubts in later parts, you can put in the comment section. Okay, so officially I finished all the lectures of throat. I'm sure nose and ear also has been covered by some other faculty. If any of you want any specific lectures on specific topic, you can let me know. I'll try to put it at my own time. You can go through it whenever you want it. Uh, that's it. Today I'm not putting any questions for link, any link for the questions. Because being a last lecture, I thought let us be a bit relaxed. I am also marking all of you present because again last lecture post Diwali. Those who have not attended, please go through this lecture at your own time. Any doubts, keep putting on comment section. So thank you so much. I end the stream. Thank you, Siddharth. I appreciate that. Okay. So thank you guys. Okay. See you.